Hello and welcome to the second Monivent webinar on respiratory function monitoring, entitled Respiratory Management in the Delivery Room, given by Professor Georg Schmölzer. Professor Schmölzer is a neonatal physician with a PhD in neonatal resuscitation medicine, and he has extensive expertise in neonatal respiratory physiology and neonatal resuscitation. He's currently Professor of Neonatal Resuscitation at the Heart and Stroke Foundation, University of Alberta, Canada, and works as a research neonatologist at the Royal Alexandra Hospital. Professor, the floor is yours.
Good afternoon, everyone. I would like to thank Monivent first for allowing me to speak today. I would also like to disclose that, given that this is just a 10-minute presentation, I will not be able to go into too much detail, and rather will just scratch the surface on several topics related to delivery respiratory management. I'm sure most of you know that most babies don't need our help to support their breathing. However, there's approximately 10% of newborn infants who do need our help, and we need to provide respiratory support. And the lower the gestation age is, the higher this number will be. Now, immediately before birth, the lungs are filled with liquid, as it is throughout the pregnancy, and the clearing of lung liquid at birth is a three-phase process, and in particular in the first minutes of birth, it's mainly focused on air liquid clearance as well as liquid accumulation in the interstitial tissue at the end of this process. The next step is basically gas exchange, where we then try to get oxygen or air into the system so that the infant can sustain their life outside the uterus. And achieving lung aeration is not something which happens with the first cry or the first breath, as it's nicely shown here by a study by Blank et al. It's a process which takes 30 seconds to a minute, potentially 2 minutes, to achieve a full lung aeration. So it's certainly not something which can be achieved with the first cry, as you can see in this data here from the term newborn infants not needing any respiratory support. Now, we also know that approximately 80% of all infants breathe or cry at birth, and when they breathe, they use different breathing patterns to aerate the lung, and crying is one of the predominant patterns. And crying is also one of those breathing patterns which frequently use braking maneuvers. It's either crying or grunting, where the infant does nothing else than narrowing the larynx or the vocal cord to increase the resistance of the expiration to try to generate some more PEEP. And another way of breaking the expiration would be that they narrow or close the glottis, and thereby increasing the intrapulmonary pressure so that they can obtain the lung volume. Now, more recently by Crawshaw et al., they described that if you have a preterm rapid pup, there's glottis closure occurring when the lung is unaerated, or they have an unstable breathing pattern. And once the lung gets aerated and the breathing pattern is more stable, this glottis closure disappears. Most concerning is that if you provide positive pressure ventilation, you might be unsuccessful because the glottis is closed. And you can see that nicely here, that in one figure A, the glottis is closed, and suddenly the glottis is opening in figure B, and then it might swap back and forth again. And if the glottis is closed and you provide positive pressure ventilation, you might deliver most of the volume into the stomach, which is certainly not something we want, because that would just get you in the distended abdomen and not the effect you want to achieve with lung aeration. Now, when infants fail to initiate spontaneous breathing, we certainly need to support their breathing, and the goals are similar than what infants do when they breathe, with the additional goal, particularly for premature babies, to minimize lung injury. Now, one of the things we have available is PEEP. However, we certainly do not know what the optimal PEEP is. What we certainly know is that PEEP during respiratory support for particular premature babies, but also for term babies, has a lot of benefits, which include a more stable breathing pattern, improves oxygenation and conserves surfactant, as well as help to establish and maintain FRC. And if you look how it looks if you provide positive pressure ventilation without PEEP, what you can see is that even though you try to aerate the lung liquid is always retracting back into the bronchial tree, and it takes quite some time to aerate the lung. So that's certainly something we try to avoid, because we want that the lung gets aerated. But this is certainly something which takes quite some time. And if you compare this now in a rabbit pup with PEEP, you can see that the lungs stay open. That's certainly a big advantage of using PEEP, because with this way you don't see the retraction of the lung liquid, you don't see collapse of the airways, if you will. So that's certainly beneficial. Now, what's the evidence for using PEEP or no PEEP in the delivery room? Now, the evidence isn't the greatest, I must admit. There's a large observational study out of Brazil which showed that if you use PEEP, you certainly have an improved survival to hospital discharge without BPD, severe IVH, or PVR. And it certainly, and I apologize for this rather busy table, it has many benefits, including less intubation, less surfactant administration, more alive in the hospital discharge, and less death in the delivery room. That's certainly something which is rather reassuring. Now, the evidence from randomized controlled trials is rather limited, and a recent systematic review by Travis-Yanuto et al. Did not show significant difference in in-hospital mortality. However, BPD was less when using a T-piece with PEEP compared to a self-inflating bag. So that's certainly reassuring. That means that during stabilization of a premature infant at birth, you should use PEEP with at least 5 centimeters of water. And always remember, a self-inflating bag does not provide PEEP, and with a flow inflating bag, it might be operator dependent. Now, one of the major steps in respiratory support is mask ventilation, and there's many pitfalls. I previously mentioned glottis closure, and this is something which was shown a few years ago, that if you provide sustained inflation, you might have issues with glottis closure. And on the other hand, when you can see this nice little waves doing a sustained inflation, that the infant was spontaneously breathing, which represents that the glottis is open and closing, or the baby is spontaneously breathing. That's certainly something which is reassuring. And the other one, it might be concerning because you do not get the gas into the lung. Now, other pitfalls with resuscitation, which have recently, with mask ventilation, which I've recently described, is certainly that the mask often doesn't fit. And if you use a mask which is too large, but also if you use a right-size mask, you might trigger the trigeminal cardiac reflex. Now, this reflex could cause respiratory depression or apnea because of the peripheral stimulation of any of the sensory branches of this nerve. Now, there's only been a couple of studies so far examining this, and what they found is either in older premature babies or in smaller premature babies that this certainly causes a decrease in heart rate, and a change in oxygen saturation, which is all related to because the placing of the face mask caused apnea. So that's certainly something we need to keep in mind when we place a face mask on the newborn's face, that it might cause apnea, which is related to placing the face mask. Some other concerns with using mask ventilation is certainly leak, which is often high and also wearable and operator dependent during neonatal resuscitation. So it could be that at one occasion you have a low leak, and on the next occasion you have a high leak. That's certainly something which is a big concern. and that potentially a respiratory function monitor could help you to reduce that leak. Alternatively, and that has never been studied in the delivery room, only in simulation, is that if you use a certain way of holding the face mask, so using the 2-point top hold with chin lift, is the best to minimize the leak with a lateral face mask. Now, there has been 2 studies, one mainly in the delivery room and one mainly on the NICU, to compare different face masks, and they found that the leak is comparable, but certainly too high in both settings. That's certainly something where the operator should work and try to aim to reduce the leak. Alternatively, nasal prongs have been described to be used during mask ventilation, and they're used routinely in several units, while face masks are routinely used in many other units. Now, there have been several studies out, and overall the comparing nasal prong with face mask for respiratory support or mask ventilation in the delivery room showed no difference in any of the outcomes. So now, while this is certainly concerning that there's not more studies, it's also reassuring that given that there's no difference, either devices are feasible. Most importantly, whatever device you use, you need to be trained to use the interface. The last thing you would like to discuss is briefly area obstruction and respiratory function monitoring. Now, area obstruction has been described very common during mask ventilation, and depending on what device you use, if you use a colorimetric CO2 device, it's often identified early on in the mask ventilation, and respiratory function monitor often described it throughout the resuscitation. However, I would like to just put this picture back into your mind that area obstruction on the respiratory function monitor could have also been glottis closure, which with many of these studies back then was unknown of or might have not been recognized. Now, from using a respiratory function monitoring in a delivery room, there's actually not much data out at the moment. There's a couple of studies who have been published who didn't find any difference when you put them together in a meta-analysis for either in-hospital mortality, chronic lung disease, or brain injury. Now, in summary, use PEEP or CPAP, beware of glottis closure and trigeminous cardiac reflex. People will always struggle with mask ventilation. Stimulation might help to overcome glottis closure. Get the lung open and then only think about oxygen and only intubate when needed. I would like to thank my staff and students at CSER for all the work they do in neonatal resuscitation research, and I'm happy to answer any questions.
Thank you, Professor, for that excellent presentation. Found it very interesting. We have time for a small number of questions if you would like to enter them in the chat box at the side of the webinar. If we don't get a chance to answer your questions during the webinar, we will follow up with Professor after the meeting and forward the answers to you. We have received one question regarding tidal volume for premature babies. What target volume range would you target, and would you consider increasing it to establish an FRC?
Okay, thanks for that question. That's a good question. So I think one of the things is there's not really a tidal volume range established. On the NICU, they often use somewhere between 3.5 to 5 milliliters per kilo of tidal volume, and that's based on a number of studies using volume guarantee, doing mechanical ventilation. And Cochrane review analyzing using this tidal volume showed that there certainly is a significant improvement in several neonatal outcomes. In the delivery room, there has been a couple of studies, mainly observational, who suggested that the tidal volume should be less than 6 mils per kilo. Many, or I think all of the respiratory function monitoring studies, and there's 2 published, and I think there's another one is currently under peer review. They used a range of 4 to 8 mils per kilo, and I think that's mainly based on expert opinion to use that range, but this is what we have at the moment. So I think it's hard to recommend any particular tidal volume range at the moment because we don't have the evidence. Would I increase the tidal volume? Potentially. I think what we don't know is how the compliance or resistance is changing at birth. So if we would know what the baby is doing, then I think we could target exactly or mimic exactly that what the baby is doing, and then might have a smaller tidal volume, a larger tidal volume at the beginning, and then once the compliance resistance is improving, then we might have just to quickly dial it down. So that might be something for the future if we ever get to know that what the baby is really doing at that time.
Okay, thank you for that answer. We've received one question here. Since when is the issue of glottis closure known in NIPPV? Is it a new observation?
Yeah, that's something which is rather new. There's that one study I presented from the group from Leiden with the sustained inflation. I think Van Vodderen was the first author, was the first to describe it in newborn babies, and Crawshaw showed that in the spontaneously breathing rabbit pups, and that's roughly a couple of years old, maybe 3 years old. So that's something which is rather new, that when you do mask ventilation, that you could observe glottis closure, and it comes from the fetal breathing movements, because a fetus, when it does fetal breathing movements, the fetus is breathing and then it stops breathing, and one of the mechanisms when it stops is closing the glottis to help with the lung development, and this reflex is basically still occurring after birth, at least at the beginning in the first minutes.
Okay, thank you for that answer. I think we have time for one final question. This one is regarding leakage. It's a key factor in under-delivery of tidal volume. Is it possible to assess leakage if we don't have a respiratory function monitor?
Well, so in general, because if, let's say you would use mask ventilation without gloves, and it's often done in simulation. I think nowadays more often they use even gloves doing simulation. But if you don't have gloves in simulation, you might feel the leak or the gas coming out at the side of the mask. But this is not something we ever should do routinely in a delivery room, not wearing any personal protective equipment. So there is no way of seeing that there is a leak or there is no leak, or how big the leak is without a respiratory function monitor. So the only way to really identify that is a respiratory function monitor. I didn't have a slide in my talk, but even if you have a leak of 80 or 90%, which is a quite significant leak, and you use a T-piece, you could still reach your set pressure of 25 or 30. So the manometer only helps if you would have 100% leak, because you don't get it. So if you have 80 or 90% leak, you will still be able to get 100%. You still get your pressure. So that manometer doesn't help you either. So the only other way would be a respiratory function monitor of any kind.
Okay, thank you for that. Professor, I'm afraid that's all we have time for. Thank you again for your presentation and for your time. Thank you for the audience for joining us. For those of you that are participating in the GMPI, enjoy the rest of your conference. And for those of you who joined us directly, enjoy your weekend. Thank you and goodbye.
Thank you. Goodbye.